Alzheimer's is the most common form of dementia, affecting more than 5 million Americans, and prevalence of this disease is expected to triple by 2050. While deaths from cancer and heart disease are going down, deaths from Alzheimer's are going up. What's being done to develop effective treatments and prevention of this degenerative brain disease? Stay tuned.
The human brain is a remarkable organ. Complex chemical and electrical processes take place within our brains that let us speak, move, see, remember, feel emotions, and make decisions. Inside a normal, healthy brain, billions of cells called neurons constantly communicate with one another. They receive messages from each other as electrical charges travel down the axon to the end of the neuron. The electrical charges release chemical messengers called neurotransmitters. The transmitters move across microscopic gaps or synapses between neurons. They bind to receptor sites on the dendrites of the next neuron. This cellular circuitry enables communication within the brain. Healthy neurotransmission is important for the brain to function well. Alzheimer's disease disrupts this intricate interplay. By compromising the ability of neurons to communicate with one another, the disease over time destroys memory and thinking skills. Neurons in certain brain regions disconnect from each other and eventually die, causing memory loss. As these processes continue, the brain shrinks and loses function. We now know a great deal about changes that take place in the brain with Alzheimer's disease, but there is still much to learn. What other changes are taking place in the aging brain and its cells? And what influence do other diseases, genetics, and lifestyle factors have on the risk of developing Alzheimer's disease as the brain and body age? Scientific research is helping to unravel the mystery of Alzheimer's and related brain disorders. As we learn more, researchers move ever closer to discovering ways to treat and ultimately prevent this devastating fatal disease.
Dr. Kerchner is an assistant professor of neurology and neurological sciences at the Stanford University School of Medicine. He is also director of research at the Stanford Center for Memory Disorders and principal investigator of the Alzheimer's Disease Clinical Trials Program. Dr. Kerchner has been on the board of directors of the Alzheimer's Association since 2012. Welcome, Dr. Kerchner. It's so good to have you here today.
Thank you very much for inviting me.
Well, let's start at the very beginning. When did we first become aware of this disease that we call Alzheimer's?
Dr. Alzheimer, who was a German pathologist and psychiatrist, he first took note of a patient, a 51-year-old woman named Auguste Dieter, in 1901. And he became very interested in her. She had problems with short-term memory, and he cared for her until she died in 1906. Being a neuropathologist, he looked at her brain at autopsy, and he saw the characteristic plaques and tangles in her brain that have come to define what the disease is. And so because he was the first one to describe how the brain looks in somebody with those symptoms, the disease has ever since had his name attached to it. But probably the disease has been around forever.
We know that cognitive change might be expected as a consequence of getting older, but what is that line between what is a disease and what is not a disease?
Diseases like Alzheimer's disease start in the brain probably at least 20 years before there are symptoms. There are subtle symptoms that gradually come into play, and eventually the symptoms become severe enough that a doctor now says that a patient has dementia. The dividing line between normal symptoms, kind of normal, typical aspects of aging from the symptoms of an illness are really defined by how a person scores on cognitive tests in a hospital. And so, for instance, when patients come to see me and their symptoms seem very mild and not at all obvious, I'll have them go through a battery of what are called neuropsychological tests, where there are kind of cut points between normal performance and abnormal performance. And that can help define whether somebody is really out of the range of what would be expected for normal aging. And that would raise my concern that there's really a disease going on in the background.
The prevalence of this disease is expected to triple by 2050. Now, is this simply a matter of people living longer and reaching the age at-risk age group, or is there something else going on here?
Age is by far and away the leading driver of risk for Alzheimer's disease. And the fact that we talk about it so much more now and see so much more Alzheimer's disease than we did in the past, and the reason why we expect to see so much more in the future is because people are living longer. There are some other factors. For instance, diabetes, type 2 diabetes, is turning out to be a risk factor for developing Alzheimer's disease. And as our society gets heavier and has more of the so-called metabolic syndrome that our society has been battling with for a few decades now.
Do we know now what causes Alzheimer's?
We don't. We understand a lot about what it looks like under the microscope. We understand a lot about what the risk factors are, but we don't know what the root cause is.
Lately in the news, we've been hearing a lot about concussions and head trauma of professional athletes as well as school children. How about head trauma?
There certainly has been a lot of important attention paid to that. I think that head trauma does raise the risk not just for Alzheimer's disease, but for other neurodegenerative diseases of aging. Parkinson's disease is another example, and Muhammad Ali was particularly famous for putting that phenomenon on the map.
Yes.
The idea that professional boxers have an increased tendency to get Parkinson's disease. But
Right.
Alzheimer's disease, too, is seen more often in people who have had a lot of bad concussions earlier in life.
How is Alzheimer's currently diagnosed?
Alzheimer's disease is diagnosed, and doctors call it a clinical diagnosis. What we mean by that is it's not a single blood test or a single brain scan that gives you a diagnosis of Alzheimer's disease. Rather, when I call it a clinical diagnosis, I mean that a doctor, like a neurologist, will take together all of the information at hand, the symptoms that the patient's experiencing, brain scan results, laboratory results, making sure that it's not, other illnesses like a stroke or a brain tumor, and putting all that information together saying that my best guess is that it's Alzheimer's disease. Still, even to this day, the definitive diagnosis of Alzheimer's disease comes at autopsy, when you can actually look in the brain and do what Dr. Alzheimer did and see those plaques and tangles in the brain.
Can you describe some new technologies that are available to make the diagnosis today?
It used to be the case, a decade ago, and even now to some extent, that a doctor would diagnose Alzheimer's disease pretty much after saying, it's not a stroke, it's not a B12 deficiency, your thyroid function is fine, so it's not all these other things, and so the only thing left is the one thing I can't test for, Alzheimer's disease. We call that a diagnosis of exclusion. But now we're in an era where we finally have available some tests that can actually lend evidence in favor of Alzheimer's disease. For instance, there's a new brain scan available called an amyloid PET scan, where you can actually determine whether somebody has amyloid plaques in their brain without opening the brain up and looking under the microscope. A doctor can also perform what's called a lumbar puncture or spinal tap to get cerebral spinal fluid. This is the water that surrounds the brain and spinal cord. And you can test for the levels of amyloid proteins and tau proteins in the spinal fluid, and that can lend evidence for or against a diagnosis of Alzheimer's disease. And there are a number of other tests like that that are still in research phases. There are people studying blood tests, for instance. And there's a lot of promise in this field of being able to look at body fluids and brain scans to help make a diagnosis. It's still not a perfect science yet. And we're still not at the point of being able to give a patient a definitive answer about whether or not they have Alzheimer's disease.
Should everybody be asking their primary care doctor to undergo some of these tests? And when are these tests actually helpful in a practical sense for most of us?
Today, we don't currently have any effective therapy for Alzheimer's disease. And it doesn't make sense to go out and do a mass screening of the population in order to find early evidence of Alzheimer's disease because we don't have a drug to give people if they turn positive.
Right.
The time in which these tests are useful is when somebody has symptoms and when the diagnosis is unclear, when it's not clear if it's really Alzheimer's disease or maybe some other cause of cognitive problems like Parkinson's disease or frontotemporal dementia or any of a number of other illnesses that can cause cognitive decline. And when a doctor has a quandary about is it Alzheimer's disease or something else in somebody who has symptoms, these tests can be useful in that situation. I dream of a future, and we'll talk about this maybe later, where we will have effective drugs available, and maybe there will be a future where screening the population for signs of Alzheimer's disease would make sense, because then there's a treatment to offer them if they're positive.
But we've been learning that lifestyle changes can slow cognitive decline. For instance, a healthy diet, exercise, and keeping mentally and socially active can potentially lower the risk of Alzheimer's. Now, are there also foods that might be harmful for somebody with the disease?
I'll take us back to a comment that I made previously about the metabolic syndrome. There's, doctors have raised concerns, other doctors besides me, about people eating too many carbohydrates and eating too many calories in general. And there is this link between type 2 diabetes, obesity, and what are called vascular risk factors, things like high blood pressure and high cholesterol that can relate to diet. All of these things are associated with an increased risk of Alzheimer's disease. So I think that things in our diet that put us at risk for that kind of metabolic syndrome probably do put us at risk of Alzheimer's disease. And healthier diets, and most importantly, regular aerobic exercise, is really strongly associated with a decreased risk of the illness. While these lifestyle factors aren't perfect, I do have patients who have exercised their whole life and they still get Alzheimer's disease. As far as we know today, exercise and these lifestyle factors are the only thing that we really have that really can reduce somebody's risk of getting the illness.
We've learned from one of our prior programs that the 4 FDA-approved drugs are most effective in the early stages of the disease and benefits about 1/3 of the patients, which really isn't, a huge percentage. Now, are there supplements that people can take to prevent or mitigate memory loss? For instance, is coconut oil effective?
I get this question a lot from my patients, and in fact, it takes just a very easy stroll around the internet to collect dozens of suggestions that people out there in the community have made. Coconut oil, all kinds of things have been suggested as being of benefit in Alzheimer's disease. And the answer that I give to my patients when they ask me that question is, for the most part, we don't know. Coconut oil has not been studied in an adequately placebo-controlled trial that we as scientists accept as the important proof of whether something works or doesn't work.
Is that in process?
Well, it takes a lot of money and a lot of patience. You can't do big controlled clinical trials of every supplement that's out there. There's just not enough patients to participate in those trials, and our society doesn't have enough money to pay for the expense of running those trials. So yes, there is work being done on coconut oil in particular, but if you look at the long list of other vitamin supplements that are out there, I can't say that the same is true, and we probably won't ever know for sure. There have been some, like ginkgo biloba, for instance, which has been widely marketed as a therapy for memory. That has been subjected to a randomized, placebo-controlled, double-blinded study, and do you know what happened?
What?
The patients on the drug did exactly the same as the patients on placebo. There was no difference.
And that's so disappointing, isn't it?
It's disappointing, but it's an example of one drug that was subjected to that high level of scrutiny and was proven not to be effective.
Now, how about vitamin E? Did that happen to vitamin E also?
So vitamin E, the pendulum has swung both directions. Back in the early 2000s, doctors thought vitamin E was fantastic. It was an antioxidant They, cardiologists were telling their heart failure patients to take it, and neurologists were taking their Alzheimer's patients to take it. And once it got subjected to one of those big placebo-controlled tests, do you know what happened there?
What happened?
The patients on vitamin E did worse.
They did worse.
They had more strokes. There were more deaths
Oh my
in the
goodness.
vitamin E group. And so the pendulum swung, and doctors said, don't take super high doses of vitamin E because it might be dangerous. There have been some other smaller recent reports that have come out that suggest that there might be some benefits in Alzheimer's disease. But those small reports are weighing against a much bigger medical literature warning of possible side effects. And so right now, as a physician, I don't recommend my patients to take vitamin E supplements.
Now, how about omega-3 fatty acids?
There's been a lot of reports of benefits there, especially for people who have cholesterol or lipid problems. And there's good evidence from the cardiology community that omega-3 fatty acids, fish oil, can be of benefit. And given that we know there's a connection between vascular risk factors and Alzheimer's disease, probably those benefits extend. I imagine it's a weak benefit, but it certainly doesn't seem harmful.
At least it's not harmful like potentially vitamin E.
Right.
Now, research into treatments for Alzheimer's disease has been just plagued by failure. Between 2002 and 2012, over 99% of trials aimed at preventing or reversing the disease failed, which is a mind-boggling statistic. What accounts for this shocking failure rate?
Yeah, I mean, it has been a really tough time to be an Alzheimer's scientist these last several years. When a trial fails, that means that the trial didn't meet its main endpoint. In other words, to make people with Alzheimer's disease score better on a memory test or score better on a list of things that they can do or not do. So when a trial fails, that means it didn't meet the threshold that they set for themselves. But nevertheless, we've learned a lot from all of these trials in the past. We've learned the importance of starting earlier in the disease, and actually a number of trials that have been quote-unquote negative, when the researchers have gone back and looked at the patients who were most mildly affected at the beginning of the study, there actually has been promise, and there have been some drugs currently in development that look promising at helping people whose memory scores are amongst the most mildly affected when they start the drug. And so we've learned a lot from these failed trials, and it's helped us to shape the future trials that are coming out now.
What sorts of clinical trials are currently underway, and are we getting closer to a cure?
There are a lot of clinical trials going on right now. I mentioned at the beginning that amyloid and tau are the two proteins that are seen under the microscope. Amyloid has gotten a lot of attention because there's a lot of evidence that points to that as being at the beginning of the disease, as setting off a chain of events that eventually leads to tau accumulation and eventually dementia. And so there's been a lot of attention by pharmaceutical companies on trying to attack amyloid, since it seems to be at the beginning of the process. And so there are clinical trials still going on using what are called antibodies. That's something that our immune system produces. Using antibodies that attach to amyloid, and the immune system then recognizes that that amyloid, because there's an antibody attached to it, must be foreign. Therefore, we got to get rid of it. And so we use the body's immune system to try to take amyloid out of the brain.
I see.
That approach has been around for a while. Doesn't look like it works on patients who really have full-blown dementia, but there are trials going on now using that approach in patients with much milder symptoms. And there are other drugs. There are oral drugs that are being tested now to try to prevent the production of that amyloid protein in the brain. And so we won't have the answers for all of these for a few more years.
A few more years. Oh dear, we have to be patient, it sounds like. I heard about a clinical trial being conducted in Colombia, South America, on patients with a genetic form of Alzheimer's disease. Can you tell us a little bit about this trial, and what does it mean for the rest of us?
Most people get Alzheimer's disease not through genetics. Genetics plays some role in the risk, but most people just get it because of age and because of other risk factors. But there's a tiny percentage of people in the world who get Alzheimer's disease in their 40s or early 50s and directly inherit it from a parent because of a mutation in their DNA. In other words, a parent will just statistically give their DNA, this mutant form of the DNA, to half of their offspring. And so 50% of the children in a family will suffer from the disease. And they will, if you inherit that bit of DNA, you will definitely get the illness. And you can actually predict within a few years the age at which the symptoms will start based on the age that the symptoms started in the parents and the grandparents. And so this presents a very interesting scientific situation where you can test somebody's DNA when they're a child or a young adult, and say you test somebody's DNA when they're 25. You can know with a certainty that they're going to develop Alzheimer's disease, say, at age 43.
Oh.
And so this allows you to, if you have a drug that has proven to be ineffective when it started, once patients already have symptoms, this presents an opportunity now to start that drug before the symptoms start, and then wait and see if that person in fact goes on to get Alzheimer's disease when they otherwise would have or not.
Is this what's been happening with this trial?
This is exactly what's going on. And so the first patients have been dosed with one of these anti-amyloid antibodies, and we're now waiting. There's a placebo-controlled form of this, so we in a study you always have to compare the active drug to an inactive drug.
Now the genetic form of Alzheimer's is very small percentage of the total population, is that right?
That's right. One natural question is that disease that this rare group of people in Colombia get, is that relevant for the rest of us? There's a lot of evidence to think that it is. Under the microscope, their brain looks the same as an 85-year-old who gets the disease just because of age. And so there's a lot of reason to think that what we learned from that trial is going to be broadly applicable to the rest of us.
And how large is this trial?
I don't remember the exact numbers, but it'll be...
but it's fairly large?
It's large enough to be able to see a difference.
I have also heard about the A4 trial. I think I heard it from you, in fact. Can you please explain what that is all about?
Well, the A4 trial is really meant to address this fundamental question of, is regular Alzheimer's disease that we all get because of age any different from this genetic form of Alzheimer's disease? So here, patients who are 60 years of age and older are being invited to get an amyloid PET scan. I mentioned earlier that this is a new brain imaging technology that allows you to see if somebody has amyloid plaques in their brain or not.
Right.
So patients who are normal, who have no symptoms of memory impairment, their husband or wife doesn't think that their memory is bad, and they test normally on a set of memory tests, but their brain scan is positive for amyloid plaques. These are the people who are going to be tested in the A4 trial and given either an anti-amyloid drug or a placebo, and then compare those two groups and see whether a drug given before the symptoms start is effective in preventing the onset of memory symptoms in the future. So that trial has started now too. So we call this a secondary prevention trial. Secondary because these are patients who already have amyloid in their brain, and prevention because we're trying to see if we can prevent any decrement in their memory in the future.
What are the barriers to moving research forward? Have we simply run out of ideas, or are there other obstacles to advancing the field?
We're lucky. We live in a day and age where we have a lot of ideas for attacking Alzheimer's disease. But there are obstacles. We don't have enough patients to test in clinical trials. It's always hard to recruit enough people. We need people in the community, people suffering from this disease, to see how important research is. We need people to be excited to participate in research, because this is the only way we can learn if these ideas work or not. Another big obstacle for us is money. Our federal government has not put Alzheimer's disease on nearly as high of a priority list as a number of other admittedly very important diseases like HIV and heart disease and cancer. What we've learned from those other diseases, take HIV for instance, there was an incredible amount of money put into HIV research in a very short amount of time in the 1980s and 90s.
Yes.
And the field became absolutely revolutionized. The same thing could happen in Alzheimer's disease. It takes a lot of money to run big research trials and to develop new ideas and to test them.
Now, why do you think it hasn't in Alzheimer's? Because it's such a pervasive disease.
There's a lot of stigma attached to cognitive decline. And I think that there's been a big tendency, an understandable tendency on the part of patients and especially their families to hide symptoms, to not be vocal about it. In HIV, we saw patients come out, march on Washington, have big rallies. They were very vocal.
Right.
And they forced their congressmen and congresswomen to vote in new money, new spending for research. We need our families and our patients with Alzheimer's disease to be just as vocal. And we need them to be out there arguing with their congresspeople, arguing with their government to get more attention to this problem.
How can everyday people contribute to this fight against Alzheimer's?
Seek help if you haven't already. Talk to people in your community. Talk to your doctors about ways that you can get involved in research. Talk to your public officials about ways you can get more attention paid to this illness.
How can we encourage people to volunteer for these clinical trials?
In part, I think what we're doing right now is helpful. I think that there's been a lot of press about all the negative results and failed clinical trials, and I think there's a lot of pessimism in the community. It's great for people to be able to hear that researchers actually have a lot of optimism, and there are a lot of good ideas being tested. So part of it is getting the message out that there's that researchers are very excited and there are good ideas, and trying to teach people about this research. I think that's the best way to get people interested.
Well, Dr. Kerchner, you have been a wealth of information. Thank you so much for being with us today.
Thank you for having me.
Thank you so much for being with us today, and I certainly hope you found our program informative. Be sure to remember to watch our shows on YouTube. See you again next week on The Better Part. Bye-bye.